Welcome to the Encephalitis Podcast. My name is Prav and I'm from Encephalitis International. Today, we will be talking about autoimmune encephalitis associated with MOG antibodies. To learn more, I'm grateful to be speaking to Dr. Matteo Gastaldi. Dr. Matteo Gastaldi is a neurologist specializing in the treatment of antibody-mediated disorders of the nervous system, including myasthenia gravis, MOGAD and NMOSD, and autoimmune encephalitis. He trained in neurology and obtained a PhD from the University of Pavia. During his PhD, he was a research fellow at the Neuroimmunology Laboratory at the Nuffield Department of Clinical Neurosciences in Oxford for a year, supervised by Professor Angela Vincent. Since 2021, he has been the head of the Neuroimmunology Research Unit in Pavia, Italy, and the co-head of its Neuroimmunology Diagnostic Laboratory. He is also involved in patient care and conducts a neuroimmunology clinic dedicated to patients with antibody-mediated disorders of the nervous system. Dr. Gastaldi, welcome to the Encephalitis Podcast. How are you doing?
I'm doing great. Thank you very much. And thanks for having me here. It's really a pleasure.
Thank you. The pleasure is ours as well. So for listeners who are new to this, what is MOG antibody-associated encephalitis in simple terms?
Yeah, so the first thing that we have to clarify here is about the name, right? Because in fact, MOG-associated encephalitis is part of a wider disease that is generally called MOG-associated disease. And this refers to the fact that this is an inflammatory disorder, it's an autoimmune disorder where the immune system attacks its own brain and specifically one protein, which is MOG. And in this disease, we have antibodies that go and target and cause damage to MOG and other parts of the brain. And the reason why this is called MOG-associated disease is that it can present with many different manifestations that depend on where MOG is located. So it can affect, for example, the optic nerve and then the vision. It can affect the spinal cord, but it can also affect widely the brain and cause a proper form of encephalitis. So we could say that MOG encephalitis is a subgroup of the MOG-associated disease.
Lovely. And as I understand it, MOG stands for myelin oligodendrocyte glycoprotein. That's correct, which is found in the myelin sheath.
That is a myelin alphabet. It's correct. This is a component of the white matter of our brain. Basically, it's not very abundant, but it's in a strategic position because it can be attacked by, for example, antibodies by the immune system in general. So that is the main target of the antibodies here.
Right. So how does MOG-associated encephalitis usually present, and what are the symptoms that should ring alarm bells?
Yeah. So this is quite fascinating to us because this type of entity has been discovered only recently, and I'm talking about MOGAD in general. And it was discovered initially as a typical differential diagnosis of multiple sclerosis. So typical symptoms there were, for example, vision loss with optic neuritis or impairment in walking with spinal cord involvement. Whilst what we discovered more recently is that this type of disease could actually mimic what we normally see in encephalitis, for example, in viral encephalitis. And here we have two main type of presentations. We have one that is called acute disseminated encephalomyelitis, or ADEM for short. This is something that is more common in children, and it's a proper form of encephalitis. So children can become more confused, more sleepy, for example. They can have strange behaviors. And then what happens is that they can have trouble walking and moving, for example, and they can have seizures as well. So it's a full-blown form of encephalitis. The other type of presentation that we get, both in children and adults, is something quite tricky to recognize because it manifests mainly through seizures. So patients start developing seizures, possibly isolated seizures. And in the end, if you do an MRI scan, you detect a small area of inflammation located at the surface of the brain. That is called focal encephalitis, something very peculiar and rarely found in other condition other than MOGAD. And it can be also tricky for clinicians to recognize this type of entity.
Right. And yeah, moving on to treatments. Once diagnosed, what does acute treatment typically involve?
So as I was saying before, this is an autoimmune disorder. It's an inflammatory disorder. So and it's associated with the presence of antibodies. So the two things that we want to do is we want to reduce as much as possible the inflammation, and we can remove as fast as possible the antibodies. So the most common treatment that is given in the acute phase are steroids, which we know it's a drug that is able to reduce inflammation. And usually steroids are given in a very high dose intravenously. And usually this type of treatment is combined with other approaches that aim directly at removing or interfering with the antibodies. One, for example, is plasma exchange, which is a procedure where you basically take out the antibodies from the blood. And the other one is intravenous immunoglobulin, which this might sound counterintuitive, but is adding a lot of antibodies in our blood. And this somehow is able to counteract action of pathological antibodies such as MOG antibodies. In most cases, patients with an acute manifestation of MOG-associated encephalitis will receive a combination of both steroids and plasma exchange or intravenous immunoglobulins.
Right. And how do you think about relapse risk and long-term treatment decisions?
Yeah, this is a good and tricky question because this is a problem for us and for the patients. And differently from other conditions that affect the central nervous system, I mentioned before multiple sclerosis, for example, MOG is a disease that can be monophasic. So it means that you can have one attack and you don't get anything else for the rest of your life. However, there is a chance that you will get another attack, so a relapse. And there are different studies on this. The number spans from 30 to 60% of patients experiencing a relapse in the future. And our biggest problem now, and the patient's biggest problem, is that we do not have precise indicators of which patients are going to relapse and which patients are going to stay monophasic, so have one attack and nothing else in their life. This is, of course, extremely relevant because imagine experiencing the first attack of this condition and having a doctor in front of you telling that he doesn't know whether this is going to come back or not. And the direct impact of this is, are we going to start a preventive treatment and a chronic treatment which controls your immune system and prevents further relapse, or are we going to, allow me phrasing, take the chance and see what happens? And this is a difficult decision now, and there is conflict about what to do, also among clinicians and experts on this.
Absolutely. And you mentioned children, and I was wondering how MOG-associated encephalitis differs in children compared to adults, if you can go into that.
Yeah, so this is a disease that affects all ages. There is a peak of incidence in the pediatric population and one in the adult population. And there are slight differences because whilst in adults, the main presentation of MOGAD are those that involve, for example, the optic nerve and the spinal cord. So as we were saying before, for example, visual loss or impairment walking. In the pediatric population, the most common manifestation is encephalitis. So this, for clinicians, this is quite tricky because we think of MOG as a disease that affects the white matter, so similar to multiple sclerosis, but actually in the pediatric population, most patients have an encephalitis. So this goes directly in differential diagnosis with viral encephalitis or other forms of autoimmune encephalitis, such as NMDA encephalitis. So this is the most typical presentation in children, is the most common that we will see as clinicians.
Right. And talking about kind of developments in research, are there any developments that particularly excite you?
Yeah, so there are many. I think this is important to understand also for patients. Many times when you will receive this type of diagnosis, you will be kind of lost, and a lot of doctors will we don't know much about this disease, and it is true because this disease has not been known for 100 years. It's quite recent, but there is a lot of research going on, and I'm sure that the next 5 years will be amazing in terms of the information that we managed to get. I think that now one very exciting piece of information that hopefully will sort out in next year will be understanding clearly what the antibodies do. Because we're not sure yet that even though the antibodies are the culprit of the disease, are the tool that we use also to name the disease, we're still uncertain of what they precisely do in our brain. And there are studies going on that are trying to characterize that in a very precise detail. And this is relevant not just because we want to understand the disease, but understanding what the antibodies do has as direct implication the possibility of using drugs that target specifically those functions and are able to cure patients. We've seen something similar in other diseases that are, let's say, related to MOG. There is, for example, NMOSD, which is a disease mediated by other antibodies. And there, researchers were able to characterize precisely what the antibodies do. And now we have a lot of treatments that we can use. So hopefully something similar will happen in MOG. Related to that, another very exciting piece of news, at least to me, is that there are clinical trials now on MOGAD that are developing a targeted drug. And particularly there are two that will be completed this year, and we're eagerly waiting for some of the results. Some of those are out, but we cannot say whether the trial was successful or not. But I think that this is extremely important because it means that tomorrow we might have drugs that are specifically evaluated in MOGAD, can be prescribed, can be supported, for example, by national healthcare systems or insurance. And I think this is really important because this makes the disease a disease that is widely recognized as specific treatments and options for patients. So this will be very exciting for us.
Yes, that is really exciting. Yeah, please do keep us posted about that. Hope results come out soon. So we are coming towards the end of the podcast, and I was wondering, what message would you want to send to patients or families listening today to take away?
Yeah, I think that probably the main message is related to what I was saying before. This is a novel disease. This might make people feel kind of lost by the ignorance that the scientific community has about this. I think the main message is people are actively studying this disease. We've been discovered so much in the past 5 years, and the next 5 years will be even better than this. So don't worry, even though some answers, for example, the one we were talking about before, am I going to relapse or not? Now we don't have a precise answer. I'm confident in the next years we will be much better at predicting what happens to you. So there is hope in the future, I'm sure.
That's a really lovely, positive message. Thank you for that. And yeah, lots of hope in the future, and good to hear about the scientific activity going on in this area. So we have come to the end of the podcast, and I was just wondering, Dr. Gastaldi, before closing, is there anything that we have not discussed that you would like to mention?
So there is one topic that is very important, I think, about this condition, and it's also something that makes people that go through the diagnostic process quite worried. And it's about the antibody testing. As you mentioned, I also work in a diagnostic lab. And one of the biggest problems that people have to be aware of in MOGAD is that the tests that we use to identify the antibodies and to assess the diagnosis are quite tricky. And a lot of laboratories can perform tests that are not 100% accurate. So sometimes people will experience symptoms suggestive of MOGAD, but will struggle to get to the diagnosis. So I think that both patients and clinicians that treat this disease have to be aware of this intrinsic limitation of the diagnostic process that we have, because the more precise diagnosis patients receive, the lower number of mistakes we make in treating them. So I think this is an important point.
Absolutely. Yeah. Thank you so much for that. And yeah, we have come to the end of the podcast. Dr. Gastaldi, thank you so much for sharing your time and expertise with us.
It was a pleasure being here. Thank you very much.
That was Dr. Matteo Gastaldi, head of the Neuroimmunology Research Unit in Pavia, Italy. Finally, I would like to thank you, the audience, for listening and watching. If you have been affected by any of the issues raised wherever you live in the world, please contact our support services. Encephalitis International is here to help in whatever way we can to achieve our aim of ending death and disability from encephalitis. For all our information and support services, please visit encephalitis.info. And if you have found this podcast useful or interesting, please consider supporting our life-saving work by visiting encephalitis.info/donate. Thank you again, and see you next time on the Encephalitis Podcast.